here today to talk about the oncology care model. We're going to discuss the clinical data and the quality measures that will be involved in this program. What is the clinical? The purpose of this presentation is first to explain why the data is needed, both for the Institute of Medicine Care Plan and the clinical quality measures, to discuss what clinical data is needed, and then to demonstrate how and where to collect this data. The Oncology Care Model is a pilot program from CMS. Its goals are to provide higher quality care for patients, coordinated care for patients, and hopefully at the same or lower cost than is currently provided. By participating in this program, we have promised to provide enhanced services to these particular patients that include care coordination, navigation, and use of certain treatment guidelines. Physicians also are expected to actively engage the patients in all aspects of their care, from diagnosis through explaining their treatment and what the expected outcomes will be. Finally, we are going to be collecting and sending in certain quality measures and how we do on those measures. And the collection of the clinical data that you will be collecting is what will provide the answers to those clinical quality measures. There are three types of reporting that will go on for the quality measures. One is called aggregate reporting. What that means is that all patients within the practice will be reported. It is a numerator over denominator. An example of this is it will look at all the patients that are at a certain stage and see if we gave them AIs or tamoxifen for hormone receptor positive disease. A second reporting level is at the patient level. This is for OCM beneficiaries alone. It is individual patient data, and we'll go over that data in a minute. The third is encounter level. What that means is that for every single encounter with an OCM patient that will be required to report information on that encounter. One of those pieces of information, as an example, is pain and plan of care for pain. Some of the clinical quality measures that we will be reporting on, and I'm going to tell you these so you'll understand why each of the clinical pieces of clinical data that we need are required. One is treatment of hormone receptor negative breast cancer with combination therapy within 120 days of diagnosis. This is why the initial date of diagnosis is important. A second one is, are we treating patients with Herceptin that are HER2 positive? That is why it's very important to capture the appropriate HER2 status. We've talked briefly about hormone therapy for breast cancer patients. They're going to be looking to see if breast cancer patients stage 1 through 3 are being treated with ER/PR positive disease. In colon, one of the measures they're looking at is lymph node positive colon patients, adjuvant setting. Are we treating them within 120 days of diagnosis? This is why collection of the lymph node status is important. Prostate, this one may not pertain to us as much because we don't do much treatment of adjuvant prostate patients, but if you do have an adjuvant prostate patient, please think of this. Other OCM quality measures that we'll be reporting: medication reconciliation every visit. Pain intensity, we touched on this. Pain intensity and the plan of care. That means if the pain registers greater than 1, we have to have a plan of care, even if it is to observe the patient. Depression screen with follow-up. If the patient is registering a certain level of depression, it will lead to a pop-up that will ask you about the follow-up plan for that depression. This is why the PCM is critical to this. If you do not collect it through the PCM, then you will have to collect this information manually. So please check to make sure your patient is completing the PCM. And if not, you need to ask them these questions. Other OCM quality measures: advanced directives, closing the referral loop, which means receipt of the specialist report if we send them out. This is going to be handled through a QCL process. Survey: CMS will be surveying all the patients for their patient experience. And there are 3 that will come from claims data, so you won't have to enter clinical information about this, but please keep in mind when they call in, if we refer them to the emergency room or they're admitted, these are the things that they'll be looking at from a claims perspective: all-cause hospital admissions, all-cause ED visits, and hospice for patients that have died. Did they receive hospice for 3 days or more? Comorbidities are very important in this particular case because the patients will be risk adjusted. What this means is they will look at the cancer patient and determine a baseline price, and depending on the comorbidities, this can add to that baseline price. It is a way of measuring acuity level for these patients. Examples of significant comorbidities include diabetes, COPD, congestive heart failure, coronary artery disease, if the patient is enrolled in the clinical trial, if the patient has had a transplant. An example of how this works: if a patient comes in with only the cancer diagnosis, let's say their baseline target price is $10,000. If they have all 6 of these comorbidities, that could increase the baseline target price to $17,500. So all of a sudden, instead of having to beat the $10,000, we need to now beat $17,500. So please do collect significant comorbidities. Okay, next we're going to talk about what data do we need. Some of this data is going to be familiar, some of it will be new, and we're also going to look at where we need to collect that data. This is the clinical data that we're going to need to submit on all patients, and depending on their type of cancer, this additional information here that is found on the staging template. Okay, we've set up here a test patient called OCM Education 2, and we're going to demonstrate what data needs to be collected and where this data needs to be collected. This patient, unfortunately, is pretty sick. The first thing we're going to look at is breast cancer. This patient has breast cancer. He is a male, so you're going to add the diagnosis as you normally would. Please be as specific as possible. We're going to look down here and find one of the right male breast cancer patients. This is a breast cancer patient. You definitely want to collect the initial diagnosis date, and if you remember, we have to figure time to treatment, so in order to do that, you have to have the initial diagnosis date. We must collect the hormone positivity because there's a clinical measure that pertains to that. Be very specific on the Herceptin data because a 1+ may not be treated, whereas a FISH positive would be treated. For staging, you don't want to just manually stage the overall stage because remember, we need the nodal status. So from the pathology report or from your physician, if it's, depending on if it's clinical or pathological, you will collect the T, the N, and the M stages. This will give you an overall stage. Something that you're probably not used to collecting, but that we must have now, is the HP grade. That will also be found on the pathology report, and you will collect that. Once you have all of this information and you verify, oh, look, I missed my morphology. You have to have that morphology. For breast cancer, they do want to know if it's inflammatory. If it's not, whatever the pathology report says, that is what you'll use. And then you'll save and affirm. Okay, there's your patient with breast cancer. Next, we're going to look at and say this patient has progressed. let's say this patient has now come in and they have it in their brain. You'll click on that. If you go under tumor, down here, 3/4 of the way down the page, there's something that says distant mets. You'll look at this, and depending on where they have it, you'll collect that information. Please note that bone marrow and osseous are different. Osseous are actually the bone metastases that you're used to seeing. Over here, you want to collect the date that the pathology report or the PET scan showed that they became metastatic to their brain, or the MRI in this particular case. And you'll save that information. That is how you document progression. Now, do remember, if it's in something in an area that is going to be treated, like in the bone, you will need to add the secondary site. Most of y'all should be familiar with doing that, so I won't spend that time at this particular time. Next, we're going to find out that this patient has prostate cancer. One of the requirements now is to have a pathology report in the system. I know for some prostate cancer patients it's difficult to find that, but that needs to be documented if we're not able to find that. If you do, we're going to go into prostate. This patient has malignant neoplasm of the prostate. And this patient was diagnosed today with prostate cancer. Again, look at the pathology report, and from the pathology, it was, let's say it was identified by needle biopsy. It is not in the nodes that we know about, and there are no distant mets that we know about. It tells you here that you have to have a valid PSA and Gleason in addition to this. It indicates that a valid PSA and Gleason score have to be selected. You'll find that on the pathology report. This determines the grade and the risk of the prostate cancer and is needed for the quality scores. The PSA can be added down here by this button, Add Value. PSA will pop up, and this is pre-treatment PSA. We're going to say the pre-treatment PSA was 6.6. Again, morphology. Adenocarcinoma. Once you go back and make sure you've collected all the different fields, click Save. Okay, that is a prostate cancer patient. The next thing we're going to talk about is multiple myeloma and where you stage for multiple myeloma. This patient has multiple myeloma and has not yet achieved remission. We're going to say it's a plasma cell myeloma. And the diagnosis date. The area that you stage, you have to save this before you can get to the staging and go back into it. The staging for multiple myeloma is in a user-defined field. Hopefully the physician has completed the prognosis. If not, please ask the physician about this. Multiple myeloma staging, There are 3 stages for the ISS staging, 1, 2, and 3. You will need the serum beta-2 microglobulin and the serum albumin in order to determine that. These are the 3 levels. And save that. That's multiple myeloma. Finally, this patient also has lymphoma. So we're going to add the diagnosis. This patient is going to have follicular in the intrathoracic lymph nodes, B-cell lymphoma. We add the diagnosis date. For multiple myeloma, for lymphoma, you go into additional classifiers. You will find the Ann Arbor stage, the first on the list. You'll need to talk to your physician about this, but this is staging for lymphoma. We're going to say this patient also has it in their spleen, so they have an extranodal site. It's in their spleen as well. Patients with lymphoma usually are determined to either have certain constitutional symptoms, which include fever, night sweats, and weight loss, or they don't. Again, that should be with your physician, should they know that information, and then you want to save that information. There are additional classifiers for central nervous system in staging and grade, but we're not going to go through that because most of you probably do not see enough central nervous system cancer to go through that now. If you're interested, please let me know, and I'll give you that information. Otherwise, we'll probably be talking to Dr. Pandy's group, and we'll go into that further with them. There's one additional set of information that we need to acquire that is not on the staging template that we'll need to collect. If the patient comes in, each time the patient comes in, we'll need their current clinical status at least once every 6-month period. It will either indicate stable with no evidence of disease, progression of the disease, or recurrence, relapse. We also need to document in a few of the cancers if they have mutations. In lung cancer, it's EGFR and ALK. In colorectal, it's KRAS, NRAS, and BRAF. Melanoma, it's BRAF. Breast cancer, we need to know what the prognostic assay, if they have the multigene or the oncotype prognostic assay, we need to know what the score was and if it was inflammatory. Mosaiq, in order to do that, we've created a single assessment where that information can be collected. If you go under assessments, you'll see one called OCM Clinical. Pretty straightforward. The current clinical status will add for the date that the patient is there. The current clinical status. Let's say the patient is still in their initial course of treatment. And then depending on if they're lung cancer, colon or rectal cancer, colon rectal melanoma, and breast cancer, their oncotype score. If these are done through CARIS, this information should flow over into this. If not, please add this additional information. Let's say in this particular case, the patient has breast cancer. They have an oncotype recurrence score of 18, and they do have inflammatory breast cancer. Patient for today. If you have any questions, please call Robert or Cheryl or Mike, and we will help you through this, or Annalee or Tamika, and we will help you through this. We also will have some screen prints of the Mosaiq slides that we have shown you today, because we realize this is a lot of information, and we appreciate your assistance with this program, and we will give you feedback and let you know how it's going.